All right, picture the scene. It is hot, it is humid, the ceiling fan is wobbling just enough to be distracting.
Uh-huh.
I am sitting in a plastic chair that is slightly too small for a grown adult. My palms are sweating so much I am genuinely worried the ink on my pen is going to run and ruin my life.
Let me guess. You are in the examination hall at Gujarat University.
I am, and I'm staring at the MD anesthesiology theory paper. I flip to section B, hoping for something kind, something, gentle. But no, there it is. The 20-mark monster. The long question.
The one that determines if you become a consultant or stay a resident forever.
Exactly. And the topic is role of ultrasound in anesthesia principles, clinical applications, and recent advancements.
Oh, wow. That is a massive topic. That isn't just a question. That is a request for a manifesto.
It's a beast. I have 40 minutes to write everything I know about a technology that has basically taken over our specialty in the last decade. And honestly, I'm panicking. I have stacks of sources in my head. Miller, Morgan, and McCall, the ICU protocols, articles by Kaushik Jyothanath, but they are all just like swirling around like a vortex.
Which is exactly why we are doing this deep dive today. We are role-playing. You are the anxious resident, trembling pen in hand, trying to synthesize all that data.
And you are.
I am the benevolent yet incredibly strict senior examiner. Our mission is to take those stacks of source material and convert them into the perfect, structured, high-scoring answer.
I need structure. I need keywords. I need to sound like consultant material. So, examiner, I've got my exam booklet open. I write question 1. Where do I even begin?
You begin with the frame. You cannot just dive into nerve blocks. You need to define what we are actually doing. It is not just ultrasound. It is POCUS.
Right. Point of care ultrasound.
Correct. Yeah. But don't just expand the acronym. Miller makes a very specific distinction here that you need to nail in the first paragraph.
Yeah.
How is POCUS different from me sending a patient downstairs to the Dungeon of Radiology for a comprehensive scan?
It's about the question you're asking, isn't it? A radiologist writes a 3-page report describing every shade of gray in the abdomen.
Yes.
POCUS is binary. It's immediate.
Yes. It answers a specific clinical question. Is there fluid in the belly? Yes or no? Is the heart squeezing? Yes or no? Is the lung sliding? Yes or no?
Oh, okay.
It is diagnostic or procedural guidance performed by the clinician at the bedside. If you don't make that distinction, that this is a tool for our decision-making, not a formal radiology study, you've already lost the framing.
Got it. Bedside, binary, clinician-led. Okay. Now, I feel like I need to give this some historical weight. Anesthesia wasn't always like this. We used to be the specialty of blind faith.
Or blind poking, if we're being honest.
Yeah.
Kaushik Jyothanath has this great section on the evolution of regional anesthesia. You need to map that journey to show you understand the context.
Right. We started with paresthesia, which is basically poking a needle around until the patient screams, "Ow, my arm!" And then we say, "Great, I found the nerve," and inject.
Effective, but, barbaric.
Yeah.
And potentially damaging. Then came the era of nerve stimulation.
Which was better, a bit more scientific. We used electricity to twitch the muscle, but it was still indirect. We were inferring where the nerve was based on the twitch, not actually seeing it.
Exactly.
And now
we're in an era of ultrasound.
We have gone from blind to sighted.
From blind to sighted. I like that. I'm writing that down.
Do it. Examiners love that narrative arc. It shows you appreciate the technological leap. And you need to mention why this is a high-yield exam topic. Miller explicitly states that ultrasound proficiency is no longer a nice-to-have luxury. It is a core expectation of modern training.
Okay.
If you can't use the probe, you aren't fully trained. Simple as that.
So the introduction is set. I've defined it. I've given the history. I've justified its importance. Now comes the part that makes my brain hurt. Section 2. Basic principles. Physics. The veg of the meal before we get to the meat. You cannot skip this.
Yeah.
If you get the physics wrong, I don't trust you to the probe, but keep it tight. What are the must-know basics?
Frequency. That has to be the starting point. Sound is mechanical wave. Ultrasound is anything above 20,000 hertz, which is the limit of human hearing. But Morgan points out that for medical imaging, we are way, way higher.
Millions of times higher. We're talking 2 to 15 megahertz. And here is where you show off a bit of technical knowledge. How do we actually make those waves? You need to mention the crystal.
The piezoelectric effect. I always struggle to explain this simply without sounding like a physics textbook or, getting lost in the math.
Think of it as a two-way street. You have these special crystals, like quartz, in the probe. You hit them with an electric current, and they vibrate. They physically change shape and scream out sound waves. That's the transmission.
Oh, okay.
But then the echo comes back from the body, hits those same crystals, and makes them vibrate again.
And that vibration turns back into electricity, which the machine then turns into a dot on the screen.
Precisely. Electric to sound to send the signal, and then sound to electric when you receive the echo. That is the piezoelectric effect in a nutshell.
Okay. I think I can explain that. Now, once that sound is in the body, what happens to it? Why do bones look white and fluid looks black?
This is all about acoustic impedance. It sounds complicated, but it's just about resistance. Or rather, the mismatch in resistance.
Mismatch, right.
Think of it like shouting in a canyon versus shouting underwater. When a sound wave hits a boundary between two tissues with very different densities, like soft muscle and hard bone, it bounces back. It reflects.
So bone reflects almost everything.
Correct. A very high reflection means a strong signal comes back to the probe. The machine paints strong signals as bright white. We call that hyperechoic.
Hyperechoic.
And because the sound can't get past the bone, everything behind it is black. That's the acoustic shadow you see behind a rib.
Whereas fluid, the sound just cruises right through. Barely any reflection.
So the machine hears silence from that area, and silence is painted black. Anechoic. If you can use terms like hyperechoic, anechoic, and acoustic impedance correctly on the first page, you've established technical competence.
Okay, now let's talk about the hardware, the transducers. In the exam, I usually just draw a square and a curve and hope for the best.
That works, but you need to explain the trade-off. This is the fundamental rule of ultrasound physics. Miller hammers this home. Frequency is inversely related to penetration.
Okay, let me try to frame this for the answer. High frequency means short wavelengths. Short wavelengths give you amazing detail, high resolution, but they run out of energy fast. They can't go deep.
Exactly. That's your linear probe, the one with the flat head. It operates at a high frequency, say 10 to 15 megahertz. It's like using a microscope. It's perfect for things right under the skin, interscalene blocks, jugular lines. You see every fascicle of the nerve.
But if I need to see the spine in a larger patient or a kidney for a fast scan,
you need to go deep. So you need low frequency, long wavelengths. They travel deep into the body, but the picture is fuzzier, lower resolution. That's your curvilinear probe, the one with the big curved head, usually 2 to 5 megahertz.
Linear for lines and shallow stuff, curvilinear for cavities and deep stuff. We'll bullet point that. Now, orienting the image, B mode versus M mode.
B mode is easy. Brightness mode, that's your standard 2D slice.
Yeah.
95% of your work is B mode. But M mode, that's a classic Viva trap. What is M mode actually showing you?
M stands for motion. It's like looking through a keyhole, right? Or a pinhole.
Use the ice pick analogy. Imagine taking an ice pick and stabbing it through the patient. M mode ignores everything else and just shows you what is happening along that single thin line over time.
So it's a graph. Depth on the y-axis, time on the x-axis.
Precisely. And why do we care? Because it proves movement. It is the definitive way to prove the longest sliding against the chest wall, or that a heart valve is opening and closing. It documents motion in a still image.
Okay, last bit of physics before we get to the fun clinical stuff. Needle visibility. This is the bane of my existence in the OT. Sometimes the needle is a bright white lightsaber, and sometimes it's just completely invisible.
That is the concept of anisotropy. It sounds like a sci-fi villain, but it's just physics. Nerves and tendons are reflectors, but they are specular reflectors. They act like a mirror. If you shine a flashlight at a mirror at exactly 90 degrees, it blinds you. The light reflects straight back.
But if you tilt the mirror even a little bit,
the light bounces off into the corner of the room. The probe sees nothing. The nerve or tendon seems to disappear. That's anisotropy.
So the practical tip and the exam point is the heel and toe maneuver. You have to rock the probe to keep that 90-degree angle to the target.
Yes. And for the needle itself, you have to describe in plane, where the needle is parallel to the beam, so you see the whole shaft, and out of plane where you're cutting across the needle, so you only see a single white dot.
Knowing where your tip is in that out-of-plane view is terrifying, I'll be honest.
It requires a lot of practice and 3D spatial awareness. But let's move on. You've survived the physics. Now we hit the core of the answer, Section 3. Ultrasound in regional anesthesia. This is where you score the bulk of your marks.
Right, the why. Why are we dragging this machine into the room for every single block? I guess they boil down to the big 3 advantages.
Bullet point them. Make it easy for the examiner to pick the boxes. Advantage 1, improved success rate.
Yeah, the sources cite numbers like 95 to 99% success with ultrasound versus, 70 or 80% with landmarks, plus faster onset and longer duration.
Much better. Advantage 2, safety. You are visualizing the danger. You see the blood vessel so you don't inject into it. You see the pleura so you don't pop the lung. You see the nerve, so you avoid injecting directly into it.
And advantage 3.
Dose reduction. This is a huge one that Miller emphasizes. With a nerve stimulator, you're just flooding the area, hoping the drug reaches the nerve. With ultrasound, you are precisely painting the nerve. You can reduce the volume of local anesthetic by 40 to 50% in some cases.
And that massively lowers the risk of local anesthetic systemic toxicity, or AST.
Exactly. Higher success, fewer complications, lower drug dose. That's a powerful trifecta.
Okay, I need to drop some specific anatomy names here to show I know my stuff. Let's take the interscalene block. If I'm writing about this, I need to describe the image.
The classic. You must describe the stoplight sign.
So probe on the side of the neck. I see the anterior scalene and middle scalene muscles. They form a sort of triangle. And inside that sandwich, I see 3 round, dark anechoic circles stacked up. C5, C6, C7.
Red, yellow, green. The traffic light. It's a beautiful image. And what are you looking for when you inject?
The donut sign. Kaushik talks about this. You want to see the black fluid completely surround the nerve, like a donut. If you see that perfect circumferential spread, you know the block is going to work.
Precisely. If you only see fluid on one side, it might be a partial or failed block. What about the supraclavicular block, the spinal of the arm?
There you're looking for the bunch of grapes. You find the subclavian artery, that big black pulsing circle. Just next to it, lateral and superficial, is a cluster of dark circles. That's the brachial plexus.
And the safety point here is crucial because right under that plexus...
It's the first rib in the pleura.
Yes. In the blind technique, walking off the rib was a great way to cause a pneumothorax. With ultrasound, you see the bright white line of the pleura. You can see your needle tip the entire time you stay away from it. It turns a high-risk block into a routine one.
I should probably also mention interfascial blocks, like the tape block, right? Where you're not aiming for a nerve, but a plane between muscles.
Yes, definitely. It shows you understand the breadth of applications. Mentioning the fascia iliaca or T-tape block shows your current.
Okay, regional is covered. Now let's shift gears to section 4. Airway. I feel like this is the section that separates the average student from the gold medalist. This is the recent advancements part of the question.
It is. It's a very hot topic. You should split it into 2 parts. Prediction and procedure.
Prediction first. We all do Mallampati scores. We look into the mouth. But they are pretty subjective and often not that predictive.
Right. Ultrasound lets you look under the skin. It puts a number on it. Miller discusses measuring things like skin to hyoid distance or anterior neck thickness. If there's a lot of soft tissue between the skin and the bone, that's a predictor of difficult laryngoscopy because you just can't lift all that tissue out of the way.
And you can actually measure the tongue thickness.
You can. A massive tongue base is very difficult to displace with a laryngoscope blade. You can also spot pathology you'd never see from the outside, like a cyst on the epiglottis or enlarged lingual tonsils. It adds objective data to your preoperative assessment.
But the real lifesaver is the procedural stuff. Let's talk about the cannot intubate, cannot ventilate scenario.
The ultimate nightmare. You have to cut the neck. You need to do a cricothyroidotomy. Now, be honest. Have you ever tried to feel the cricothyroid membrane on a 120-kilogram patient with a short, thick neck?
It is impossible. It is just a wall of soft tissue. You are just poking blindly and hoping you hit the right spot.
Miller and Morgan are very clear here. Palpation is wildly inaccurate, especially in obese patients. Ultrasound is precise. You put the linear probe on the neck, you see the thyroid cartilage, the big bright white line. You slide down, you see the cricoid ring, the hump. The gap in between is your target.
So you would mark it before you induce anesthesia in a high-risk patient?
Absolutely. That's the key. You do a pre-flight check. You map it. You draw a line with a marker. If things go south, I know exactly where to make the incision.
Yeah.
I'm not guessing. I'm executing a pre-formulated plan.
That's brilliant. That is safety. Now, confirming the endotracheal tube, this is a bit of a controversial one, isn't it?
It's a Viva trap. I know you know this one. The 2020 ICU protocols make it crystal clear. Ultrasound is an adjunct. It does not replace capnography.
Right. Capnography is the gold standard.
But what if I'm in cardiac arrest and there's no cardiac output? The capnograph might be flat even if the tube is in the right place.
Bingo. That is the niche. If the heart isn't pumping blood to the lungs, there is no CO2 to measure. In that specific low-flow state, ultrasound becomes incredibly valuable, maybe even superior.
So what am I looking for?
You put the probe on the neck, just above the sternal notch. If the tube is in the esophagus, you see the double-tracked sign. You see the trachea, and right next to it, you see another round, empty tube. That's the esophagus with the ETT inside. It looks at the 2 tracheas side by side.
And if it's in the trachea?
Then you only see one tract. But the better confirmation is to look at the lungs. You slide the probe onto the chest. You look for lung sliding. If the lungs are sliding bilaterally, you are ventilating them. It's immediate real-time feedback.
Okay, moving down the body, section 5, neuraxial, the spine. Now, I see people scanning backs, but we don't usually leave the probe on while we put the needle in for a spinal or epidural, do we?
Not usually for adults, no. The bone is too dense. It casts a huge shadow over everything. For adults, as Miller says, it is a pre-procedural mapping tool. It's ultrasound-assisted, not ultrasound-guided in real time.
We are scouting the terrain.
Exactly. The challenges are real, right? Obese patients, elderly patients with arthritis, scoliosis, finding the midline by palpation can be a nightmare.
So what are we scouting for?
3 things. 1, you're identifying the true midline by finding the spinous processes. 2, you're finding the interlaminar space, the window between the bones where you can actually pass the needle. And 3, importantly, you can measure the depth to the epidural space or dura.
Which prevents you from going too deep and causing a dural puncture.
Yeah.
I need some descriptive terms for the landmarks you'd write in the exam.
Examiners love the sawtooth pattern. That's when you're in the longitudinal paramedian view and you see the lamina lined up like teeth on a saw. Or the bat sign. That's in the transverse view, where you see the transverse process looking like a bat swing. You find the best window, mark the skin, and then scrub up.
But you mentioned adults. What about kids?
Ah, yes, the pediatric advantage. This is a key point to make. In neonates and infants, the spine isn't fully ossified yet. It's mostly cartilage. Ultrasound goes right through it.
So you can actually see the spinal cord.
You can see everything. You can see the cord, the conus medullaris, the cauda equina, the dural sac. For a caudal block, you can watch your needle enter the sacral hiatus and see the local anesthetic fill up the space in real time. It's safer, faster, and Kaushik notes it significantly reduces the number of attempts. It turns a blind guess into a visual procedure.
That is incredible. Okay, section 6, vascular access. Honestly, this feels like the one area where the debate is completely over.
It is. The ICU book and Miller are unequivocal. Ultrasound for central venous cannulation is the standard of care. If you are doing blind stick internal jugular veins in 2026, you are going to be very hard to defend in court if something goes wrong.
And the main safety feature is distinguishing the carotid artery from the internal jugular vein.
And how do you do that? And don't just say color flow Doppler.
Impressibility, that's the primary method. I push down with the probe. The vein, which is a low-pressure system, collapses. The artery, which is a high-pressure muscular tube, fights back and stays round.
Plus, the artery pulsates. But I've been tricked by that before. Sometimes the IJV pulsates if the patient has severe tricuspid regurgitation or heart failure.
Which is why compressibility is king. The other major safety aspect is needle tip control. You want to avoid the posterior wall puncture.
That's where you go through the vein and out the other side, and then you hit the lung or the carotid artery, which is sitting right behind it.
Exactly. You must learn to chase the tip. Move the probe, find the tip. Move the needle a little, move the probe. You inch your way into the vessel. If you lose sight of the tip, you stop and find it before advancing.
Chase the tip. I'll write that in the answer. And it's not just for central lines, right? Difficult peripheral IVs, too.
Absolutely. For edematous patients, obese patients, former IV drug users, it's a game changer.
Section 7, critical care. The BLE protocol. This is where we act like physicians, not just technicians.
This is Dr. Lichtenstein's legacy. Lung ultrasound. And it's all about interpreting artifacts. Since the lung is full of air, we shouldn't really be able to see it. But the air is in the image, the artifacts, tell us the pathology.
Okay, let's run through the key signs. Pneumothorax.
Absence of lung sliding. The lung is collapsed away from the chest wall so it can't slide. And specifically on M mode, you see the barcode sign. Instead of the normal seashore sign, which is the sandy graininess of moving lung tissue, you just see straight, parallel lines, static.
Pulmonary edema, fluid in the lungs.
You look for B-lines. These are comet tails. They look like vertical, laser-like beams shooting down from the chloride to the bottom of the screen. If you see 3 or more in a single intercostal space, that lung is wet.
And pleural effusion.
That's fluid outside the lung, in the pleural space.
Yeah.
Looks black, anechoic. You might see the quad sign, a square shape formed by the shadows of the ribs in the fluid. Or, on M mode, the sinusoid sign, where the lung line floats like a jellyfish in the fluid with each breath.
We also use it for the stomach, right? Gastric post-EOS.
Yes, very useful for the emergency patient with an unknown NPO status. You look at the antrum of the stomach. If it looks like a flat bullseye, it's empty. If it looks like a starry night full of speckled hyperechoic stuff, that's solid food, you need to treat them as a full stomach.
So it directly changes your anesthetic management. You might do a rapid sequence induction.
Exactly. That's the point of Piezoelectric. And briefly, you should also mention FATE, or focus.
Focused cardiac ultrasound. Again, we aren't doing a full echocardiogram. We are just asking a few simple questions. Is the heart beating? Is it empty, suggesting hypovolemia? Is it full and barely squeezing, suggesting failure? Is there a big black ring of fluid around it, suggesting a tamponade?
It's all about shock differentiation at the bedside.
Okay, we are in the home stretch. Section 8, recent advancements. I need to show I'm reading the journals, not just the textbooks from 5 years ago.
You should definitely mention POUSEA. Using ultrasound during the pulse checks in a cardiac arrest to differentiate the causes of PEA or pulseless electrical activity.
Right. You were looking for reversible causes. Is it a massive PE? Is it tamponade? Is it severe hypovolemia? It guides your ACLS algorithm.
ERAS protocols. Enhanced recovery after surgery.
Huge. This is the rise of the fascial plane blocks. TAPI blocks for abdominal surgery, the PEX blocks for breast surgery, erector spinae plane blocks for thoracic surgery. We aren't blocking a single nerve. We are flooding a plane with local anesthetic to numb a whole region of the body wall.
And these depend entirely on ultrasound. You cannot feel a fascial plane.
Not at all. And the benefit is massive opioid reduction, which means less nausea, faster mobilization, and better recovery.
And AI. Is the robot coming for our jobs?
Not yet. Miller touches on this. AI is currently helping with image acquisition and interpretation. It can auto-label the anatomy on the screen for you or auto-count the B lines in a lung scan. It's an assistant, a co-pilot, not a replacement. It helps the novice get a better picture faster.
Good. Section 9. Limitations. You have to be balanced. You can't just say it's magic.
No, you have to show you're a critical thinker. So I'd mention artifacts. Subcutaneous emphysema, which is just air in the tissues, completely destroys your view. And obesity degrades the image quality because fat scatters the beam.
And the biggest limitation of all.
The human holding the probe.
Operator dependency. It is a learned skill. It requires hand-eye coordination and a deep understanding of 3D anatomy from a 2D screen. And it requires maintenance. As Miller warns, it is very easy to see what you want to see, rather than what is actually there.
Mistaking a lymph node for a nerve is a classic rookie error.
Or mistaking the carotid for the IJV, which is a deadly error.
Okay, finally, section 10. Future directions and conclusion. How do I wrap this mammoth answer up in a neat little bow?
The narrative arc is ubiquity. Ultrasound is becoming the visual stethoscope. Handheld, pocket-sized devices that plug into your phone are making POCUS available everywhere, from the ICU to the ambulance. The future is integration into the medical school curriculum, not just residency. It's a fundamental skill, like listening to a heart.
So the conclusion should be punchy and summarize the key themes.
Reiterate the holy trinity of anesthesia ultrasound: safety, precision, and real-time decision-making.
Safety, precision, real-time decision-making. I like that.
Then you summarize. Say that it has transformed regional anesthesia from a blind art to a visual science, it has secured the central line as a standard of care, and it has provided an invaluable safety net for the difficult airway and the critically ill patient.
And then I put my pen down, wipe the sweat off my forehead, and pray for at least 15 out of 20 marks.
If you write that structured answer with the diagrams. Wait, we forgot the diagrams.
Diagrams. Section 12. I need to draw. I'm not a great artist.
You don't have to be. You must draw. A simple line drawing of the interscaling traffic light or the airway's string of pearls is worth a page of text. It proves you have the image in your head. Draw the probe position transverse versus longitudinal. Label the needle trajectory. It shows a deeper level of understanding.
Okay. Structure, headings, keywords, physics, clinical applications, and diagrams. I feel better. I feel like I can actually tackle this. It's not just a list of random facts anymore. It's a story about better, safer patient care.
That's the spirit. You aren't just memorizing for the exam. You're learning to be a safer anesthesiologist.
Well, thank you, examiner. That was intense, but incredibly helpful.
Always happy to grill a resident. Keeps me sharp. Now go and practice.
For everyone listening, especially those poor souls preparing for the Gujarat University exams or the DNBs, visualize the anatomy. If you can see it in your mind's eye, you can find it with the probe.
And if you can find it, you can block it, cannulate it, or diagnose it. Good luck.
Good luck, everyone. Go get those marks. This has been The Deep Dive. See you next time.